As far as genetic testing, I think that this has really evolved over the last several decades. And as we've had improvements in the testing, not just from looking at genes such as BRCA1 to P53 that are inherited genes among many others, with the improvement of next generation sequencing and able to look at many genes at once in a more cost-effective way, we've really changed the face of cancer care now and in the future. For patients that might inherit a gene, finding it early, further screening and prevention steps can be taken. And for those patients now with a diagnosed cancer, knowing those mutations exist are really important because they now have therapeutic implications, which they didn't have just a few years ago. There's been a lot of controversies on who should test and when they should test and what sort of counseling should be offered. And this debate continues. Should we test everyone with cancer? Should we test everyone? Can our healthcare systems handle that at this time? I think that a lot of the different guideline committees are moving to a wider net of testing with more specific guidelines on what to do if a mutation is found, and more of making sure that the well-trained genetics professionals are interacting with those patients who either need pre-test counseling or need to have the post-test counseling. The concern also is that as we just add more genes to a panel where we might only have actionability or enough clinical information to make any sort of recommendation, or 9, 10, or 11 genes, but there's 80 genes on a panel, there can be a lot of misunderstandings and overinterpretations for genes that have little to no risk associated with them, and making sure that there's resources for those patients who find mutations or changes in genes that we don't have enough information to see if they're even clinically actionable will be a really important part of genetic counseling going forward.